Such a pleasure to be here. It's just been a wonderful opportunity to work with Claudia and David over the years. I think in the previous session, Claudia mentioned the importance of really taking a comprehensive look that takes into account all body systems. And she's really put this thinking into mind over the years and has reached out to many people at Mount Sinai and elsewhere to look at additional organ systems, and in my case, liver, which you're probably all aware as radiologists, that finding liver steatosis is very common in imaging studies. In fact, about 38% of adults in the United States have excess fat in their liver, which is defined as liver lipid content over 2%. And most of these people have a disease called metabolic dysfunction associated steatotic liver disease, which really is a disease that comes to us because of toxic exposures that result in liver steatosis, diagnosed as MASLD, when liver steatosis is accompanied by elevated BMI or hypertension or hyperglycemia diabetes or hyperlipidemia or low HDL. You only need one of these in combination with liver steatosis for a diagnosis of MASLD. And as Susan ably pointed out, all these exposures interact with our genetics and physiology to result in type 2 diabetes, insulin resistance, and can result in cardiovascular and kidney disease. Now, fortunately, MASLD itself has a very low case fatality rate. I think it's often discussed by hepatologists as though it's a terrible mortality risk factor. But in fact, in comparison to alcohol-related liver disease, oops, sorry, let's see, yep. It's a fairly minor cause of liver-related death. In this graph, the mortality curves for African Americans are highlighted in pink, and it's interesting to note that for both MASLD and alcohol-related liver disease, the risk for mortality is much lower in African Americans, just highlighting the disease heterogeneity. Fatty liver can be diagnosed in non-contrast chest CTs, not the more mild form of the disease. Oops, sorry. Oh dear. Oh, pointer. The more mild form of the disease on the left, which is obvious fat accumulation in less than 30% of hepatocytes, cannot be diagnosed in chest CTs. Chest CTs can diagnose moderate to severe, which equates to a fat fraction of about 17%. And this is to say that the gold standard for diagnosing fatty liver is either biopsy or MRI. A CT scan detects about 50% of the cases of MASLD. It can be detected by CT because it changes the attenuation. And as we have found, you can develop algorithms to identify patients with steatosis. And as Susan mentioned, we've been working with Mort and his colleagues to help them develop AI algorithms, in this case, analyzing the relationship between AI-determined fatty liver disease and outcomes. So long-term studies, and I want to emphasize this is a 27-year follow-up of liver steatosis, actually did not find any association between liver steatosis, cardiovascular death, cancer death, or liver-related death. It did show an increase in diabetes death. And this is one of the reasons why if you see liver steatosis in your radiology image, please report it, because it can be used to get important information about disease risk factors beyond liver disease, in this case, diabetes. So fatty liver, as Susan mentioned, has a strong genomic component. The first polymorphism found to be associated with liver steatosis was in a gene called PNPLA3. And interestingly, further analysis has revealed that this is a polymorphism which probably confers a considerable survival advantage to life in the cold. This polymorphism that we associate as a risk factor for liver steatosis actually was present in 100% of the ancient genomes that we have from Neanderthals. And as people migrated out of Africa, this polymorphism arose and is now present in 8 to 72% of the human population. The prevalence varies by race and ancestry. It's much higher in Latinos and very low in African Americans. And this is a polymorphism that does confer a significant increased risk for liver-related events, 2.5-fold. So this is a very major risk factor. I want to emphasize that. Sometimes we concern ourselves with risk factors that might increase an outcome by, say, 20% or 30%. This is something that is increasing by 2.5-fold, and the risk varies with visceral fat. As Susan mentioned, the weight-hip ratio. And you can see if you have a low amount of abdominal subcutaneous fat, it still increases the risk over 2-fold to have 2 copies of this variant. But if you have a high waist-hip ratio, it increases over 8.5%. Interestingly, the associations between the site of fat distribution and new onset diabetes varies by race, as I'm highlighting here in this study that we did with Morton and his colleagues, which showed that only in African Americans was epicardial fat the site of ectopic fat that was most strongly associated with type 2 diabetes. So there are interventions for MASLD. They really focus on lifestyle. Thyroid hormone receptor beta agonists and GLP-1 receptor agonists are already in use in the clinic, and more treatments for MASLD are coming in the pipeline. So I just want to conclude, for comprehensive screen to realize its promise, public health will need to participate with healthier eating, giving up cigarettes, and exercising more. We really cannot solve this pharmaceutically. Most liver steatosis is due to metabolic stress, which acts on genetic susceptibility. Exposure to metabolic stress underlies the association between liver steatosis and cardiovascular disease. Liver steatosis is a risk factor for new onset diabetes in most populations, but epicardial fat is the most significant imaging risk factor in African Americans. And together, CT imaging and genomic data are a powerful combination for probing both the mechanisms of disease and finding novel therapeutic targets. And I just want to end by thanking everyone who has been my colleague and a tremendous pleasure to work with. So thank you.